I want to say last year when I was here, I think I did predict we would have a drug bill done. So I kind of have an understatement there. And at that time, we actually started working on H.R. 3 in October because the House Democrats had run in the election of 2018 about lowering health costs, mainly by lowering prescription drug prices, wage stagnation or making the middle class better off, and then the third platform was better government, oversimplifying. And at this time last year when I was here, we had assembled, we had started to meet at the committee staff level. We had assembled a small outside team that was working with us, and I thought we were fairly far along when this conference was actually, when I was here. And I would argue that H.R. 3 also perfectly matches the administration's rhetoric about drug pricing, so why shouldn't we be able to get to an agreement? Well, there were lots of hiccups along the way, and we actually didn't pass H.R. 3 on the House floor until the second week of December. I'm not going to go through all of that, but anyway, I thought we would be further along. Sarah mentioned that we're going to have an avalanche of new drugs. There's some amazing cures coming down the pike. This SMA drug, spinal muscular atrophy, affects 400 babies, but instead of dying by age 2, they may have actual true life expectancy like all of us. And so that's why Sarah's chart said the 2.1 million is a reasonable price for it because it extends life that much. Now, the economist in me says, going to that last one, I'm not so sure we ought to, believe me, I believe ICER is performing an important service, but the economist in me says we ought to find out how much R&D actually went in. Let's give the pharmaceutical company a bonus, let them earn a real rate of return on those investments, but let's find out what the true cost is of producing that drug. Because I think we're going to have a whole bunch of CAR-T, cell and gene therapies, et cetera, that we cannot afford paying for value for everything. It ultimately has got to reflect what I'll say is economic cost. John told you about the complexity of the drug supply chain. And the one thing I want to say about the economics of drug development, that first pill may cost $500 million, $1 billion, $2 billion. But then on a lot of them, this is not true of CAR-T, but on a lot of them, then the price goes to dollars. So you've got a huge upfront cost. And that's why you can have these huge discounts to veterans and other, let's say, favored population. But that doesn't mean they want that price to apply to the entire population. So I'm not going to go through this chart. You've already heard about it. The one thing I want to say, though, is drug spending is very skewed. So if you look at in 2018, the Part D drugs, the top drug is Ecologus. We spend $5 billion in just the Medicare program. It's not the total spending. And it's and the average spend, it's about 1.7 million beneficiaries get it at about $3,000 per year. The next drug is Revlimid, and we spend $4 billion on that, but only 40,000 people, and the cost is a little over 100,000 per person. So you see, if you go through these drugs, some you have, you know, a $1,000 price, 3,000, 4,000, and lots of beneficiaries. And then you've got a few drugs where there is a few beneficiaries and a huge cost. But the first drug I said was $5 billion. The 100th drug is only $300 million. And in the Part B program, the top drug we spend on is 2.6 billion. And by the time you get to the 100th drug, it's around 20 million. My point is that drug spending is very skewed. this is a Ways and Means study that shows, again, we pay about 4 times on average relative to other countries. That shows you that drug spending has really increased in the 90s and early 2000s. And you've seen a slide like this before where voters overwhelmingly say the price of drugs is unreasonable, which gives us the political impetus to get something done. So I would respond to John in the following way, and that is, I agree with Liz that what they put forth was very ambitious. But the basic problem that the administration faces is they don't have the authority or the tools to do what they want to do. Clearly on negotiation. In Part D, we have this non-interference clause that basically says you can't negotiate with drug companies. And I know John talked a lot about the rebate rule, but the problem is if rebates go away, there is no limit on what drug manufacturers can do. They can just raise their prices. And basically, the CMS actuaries and CBO said exactly the same thing. That's what was going to happen. And that's why I keep telling the administration for the last 18 months, come to us and ask for legislative authority. And the other thing you need to ask for is tools. Prior to the development of H.R. 3, and I think Liz will agree with me, when you asked CBO if you negotiate, would there be any savings? And the answer was no. And the reason was they didn't have the tools. And so you really had to combine the authority, the mandate, and the tools for the secretary to effectively negotiate with drug companies. Because you can give them negotiation authority, but if you don't have, the secretary doesn't have clout, there's nothing that's going to cause the drug manufacturer to come to the table. And I think the reason we haven't seen the IPI rule is the administration is stuck. They can either say please, and they won't do anything in terms of lowering drug prices, or they could say you can only sell it if you agree to the secretary's price, and if you don't agree to that price, you can't sell it. Now, I think on one of the charts, I don't think the American public is going to buy using that as the stick, if you will, for negotiation. And that, I think, is the reason you have not seen the IPI rule. And if I had to bet, I don't think you'll ever see the IPI rule, because they either have to say please and get no effect, or they have to go to this thing where they say we're potentially going to withhold the drug from Medicare beneficiaries, and that, I think, is trouble for any administration that would propose that. So basically what we did, we have negotiation, the inflationary caps, the Part D restructuring, and then we plow a lot of money back into making the Medicare a much better program. So the authority comes from effectively repealing the ban. The mandate must negotiate a minimum of, the committee reported version was 25 drugs, up to a maximum of 250. I think in the early part, it's going to take a long time for the secretary to figure out what the price ought to be. And the tools basically are, we get from the drug companies on a confidential basis the information on how much the R&D cost was, what is the cost of production, what are sales, what are the prices in this country, other countries, et cetera. Transparency is the secretary has to announce which drugs are going to be negotiated in a given year. We explicitly say you take the drugs where you think you can save the government the most money. So you're basically going to start with where you can think you can get the greatest reduction relative to other countries, basically, and the high-priced, the drugs where we're spending the most money. And then you put a ceiling price, 120%, it could be 130. That number is somewhat important, but you put an upper limit on what the secretary can agree to. And then the stick is, if the drug company isn't willing to come to the table, you charge an excise fee of 95% on current sales. Now, that's a stick that the Office of the Actuary and CBO said will never get applied because it's to force compliance. Now, why did we need 95%? The truth is, we don't need 95% in a lot of cases. If our price is twice that of, let's say, Western Europe, you don't need a 95%, because we did not want the drug manufacturer to pay that, I'll call it a non-compliance fee, and walk away and just give the Treasury some money. We actually wanted the price lowered for the American consumer. So if our price is only twice as high, probably the non-compliance fee can be about 50, 60%. But if the price in other countries is 5 times or 6 times or 7 times, that's when you need a non-compliance fee of 95%. Otherwise, if you just had 50, let's say, which sounds like a big number, the drug company would pay that non-compliance fee and continue to do what they do. So that was the thinking behind those tools. And it's really the authority, the mandate, and the tools is why CBO said that Title I, the negotiation title, saved $500 billion over 10 years. $500 billion. And at that time, we were only negotiating on 230 drugs. So just think about it this. Negotiating on 230 drugs returns to the federal government $500 billion. So that's what H.R. 3 basically does. The inflation rebate is similar to the Senate Finance Bill, as Liz said. Requires that any drug that increases its price above the rate of inflation has to give a rebate back to the Treasury. Our base year is 2016, Senate Finance is 2019, et cetera. And then we had a Part D restructuring. We have an out-of-pocket limit of $2,000, Senate Finance is $3,100. And this next chart, which I'm not going to go through in detail, but it basically shows as you go up the price of a drug, the first $435 is paid for by enrollees, and then the next split is under current law, 75% on the plan, 25% on enrollees, et cetera. And then the chart on your right is the new policy where we put a lot more cost, if you will, on the plan to do a better job. And that I think there's pretty much universal agreement that we need to go to something like this. Then we put the savings into a dental benefit, vision, and hearing. So we spent the $500 billion. We didn't want to go to deficit reduction. But, we improved the Medicare. The thing about Medicare for All programs, it's branding. I mean, Medicare is not a generous program. Most of the elderly have to buy a supplemental plan. It doesn't cover dental and vision and hearing, et cetera. So we made significant improvements to the Medicare program and also enhanced the low-income subsidy programs by reducing premiums basically for low-income people, but we didn't charge beneficiaries at all for these new benefits that we were adding to the Medicare program. We also invested in NIH and FDA. We put some money to deal with infectious diseases, which also have market failure. We put some money there, which I think is very important, into FDA, maybe BARDA, et cetera. This basically shows you that when you ask voters about this, the favorability is like 70, 80 to unfavorable only 7. I mean, and my boss's, Speaker Pelosi's favorite, one of her lines is, public sentiment is everything. So I remain optimistic that we're going to do something significant in this session of Congress. We have a May 22 date, which was agreed to by the administration in the budget negotiations in December, where we said we're going to do extenders. So the extenders, the community health centers, disproportionate share, there's a whole slew of things that there's a deadline of bad things happen on May 22 if we don't get it done. And so we're going to try to get surprise billing done, drug prices, and these extenders. And that wasn't a date that was agreed to by the administration over, to some extent, McConnell's objection. And so we'll see if we can get there. As I've said, this saves a whole slew of money, and we both got the CBO and the actuary to agree that the savings were significant. I would say, to Liz's comment, what does the industry say? They say one thing time and time again, and they get the chamber and the NAM to say it as well: it will hurt innovation. CBO said it would hurt innovation a little bit. 7 drugs may not get developed. My argument is, because we're lowering prices here, to put that $500 billion in context, that's about 7–8% of sales here. It's about 5% of global sales. They can probably recover some of that reduction in sales by charging Western Europe more, or other developed countries, et cetera. We think it will reduce incentives for investment in Me Too drugs. And there's one key phrase in the bill. It says the secretary shall reward innovation. And we leave it up to the secretary on how that exactly is done. We expect there to be a fair rate of return to pharmaceutical companies. We are not driving them out of business. And they're in the business of innovating, finding new cures. And I think that will continue. The reason I'm still somewhat optimistic that we're going to get there is that this president has talked a lot about negotiation, about lowering prices in this country to that are paid by Western Europe. And you can see some of his quotes. When it comes time to negotiate the cost of drugs, we're going to negotiate like crazy. If we negotiate at the price of drugs, Joe, we'd save $300 billion a year. It's unacceptable that Americans pay vastly more than people in other countries. So I think because Trump said those things over and over and over, that we still have a shot at getting it done. I guess my conclusions are, because we have saved that much money, if we don't get it done this year, we're going to get it done sometime in the near future. We have this May 22nd deadline, and right now we're working like crazy to get the surprise billing done. The 3 committees in the House reported legislation. One committee was quite different than the other 2, and we have to reach a compromise there. And the last thing I would say is basically there's overwhelming public support. Now, the one drawback that I will say, and it goes to the Kaiser, the last panelist on the first panel, was guess how many people know that the House passed this bill that saved $500 billion? Exactly 20%. This is a Kaiser poll, I think, that was conducted in January. And, you know, all during impeachment, I would yell at the TV screen because they didn't cover that we were, you know, the House was passing a trade agreement or the appropriation bills or H.R. 3. It was all about impeachment. So as a result, the American public does not understand what we've done. And until they do, I think it's a little hard to mobilize public opinion to help us get this across the finish line. Thank you.